The information that you receive on Exclusively Inclusive podcast is designed to be a learning experience for patients and listeners in order to supplement their own information so they can be better equipped to be advocates in their own healthcare journey. The opinions expressed by Erin Everett are the opinions of her own and do not represent any third parties or separate entities. In addition, the specialists that present on the show are also here to supplement your own healthcare information and are not designed to replace any treatment plans or information you're receiving from your own healthcare specialists. We hope that you enjoy the show and continue to subscribe and listen in.
The orchiectomy that should be performed for gender dysphoria does have some technical considerations, namely where we place the incision. So, we'd like the incision to be in a cosmetically appearing location so that if the patient does decide to undergo subsequent gender reassignment, that the scar doesn't cause any major issues, with the cosmetic appearance of gender reassignment later down the line.
Welcome to Exclusively Inclusive, your source for the latest in LGBTQIA healthcare, transgender HRT, and personal empowerment. Here's your host, Erin Everett.
Hey everybody, welcome back to Exclusively Inclusive. I'm your host, Erin Everett, nurse practitioner. Really excited about today's episode because I think it's going to be really helpful and useful for the community. Today we're going to be having a very special guest, Dr. Chirag Dave. Dr. Chirag Dave is someone that I collaborate with on a regular basis to help with my patients, and he actually is located here in Atlanta and native to Smyrna, Georgia. Dr. Dave is affiliated with Advanced Urology and has extensive experience in all things urology, especially as it pertains to infertility, andrology, erectile dysfunction, voiding dysfunction, but also he is able to provide a certain level of gender-affirming care for patients, including therapeutic orchiectomies. Dr. Dave completed his medical training and degree at Northeast Ohio Medical University, where he graduated in the top 10% of his class, which is no surprise after speaking with him. He also completed a general surgery internship and urology residency at William Beaumont Hospital in Michigan, where he gained considerable experience in general urology and advanced endoscopic, laparoscopic, and robotic surgeries. After completing that, Dr. Dave went on to complete a fellowship in genitourinary reconstruction, sexual and male reproductive medicine at the Johns Hopkins University School of Medicine in Maryland. It was also here that he was able to gain experience with trans women and the gender-affirming process as it pertains to surgeries. Dr. Dave is very passionate about helping his patients in any way that he can, and I can attest to that as he's helped many of my patients achieve what their normal functioning can be, and to also help them have pain relief with painful erections, allow them to have therapeutic orchiectomies, and also something as simple as providing trans-friendly care for those who have renal stones and other urinary issues. So, without further ado, I would love to introduce Dr. Dave to our show, and let's get started. All right, so on today's show we have Dr. Chirag Dave. Welcome to the show.
Thank you. It's a pleasure to be with you and get a chance to virtually meet your audience today.
Yeah, I'm really excited. I think the things that we have on the list of topics today is going to be really helpful for the community. But before we get started, just tell us a little bit about yourself and kind of where you're practicing right now, what your passion is as far as urological care, and maybe like a fun fact about you that nobody else knows or wouldn't expect.
Absolutely. So I am a native of Smyrna, Georgia. So grew up in Smyrna, went to school in Marietta, and essentially I'm an Atlanta native. But, when I graduated, attended college in Chicago, went to medical school in Ohio, and that's kind of where I initially became interested in urology. It was during a gynecology rotation, ironically, as a third-year medical student where, I kind of realized urology would afford me the opportunity to be a surgeon, but also follow my patients long-term and kind of address, kind of chronic and lifestyle issues. But I think what really attracted me to the field was just the sensitive nature of the problems and how we really had effective solutions that could kind of give immediate gratification to the patients, but also to the treating surgeon and physician as well. So that and ended up doing a 5-year urology residency at Beaumont. So that consisted of 1 year of dental surgery followed by 4 years of urology training. So urology training was kind of exposed to all aspects of urology, but became specifically interested in which included transgender, infertility, and my general urology training. I went into reproductive medicine at the Johns Hopkins University in Baltimore. Dr. Arthur Burnett and Dr. Amin Haradi. And that was an outstanding experience in all aspects of sexual health, but also involved in a very busy transgender health program as well as a reconstructive urology unit. And so was involved in lots of interesting surgeries, but also really got to know the transgender population and some of the sensitivities that goes along with that. And hopefully that's given me kind of a unique perspective as a urologist to kind of approach some of these issues from different angles. And then recently I decided to move back to Atlanta, where I've joined Advanced Urology. I'm primarily located in the Marietta office, but we'll work in Sandy Springs as well. And was fortunate to meet you, Erin, and I've had the pleasure of taking care of several of your patients, and always love having interesting discussions with you about these patients as well.
Yeah, it's super fun stuff.
I guess a little known fact about me, besides the fact that, grew up here in Atlanta and kind of gone on a long circuitous route. My wife is actually a nephrologist, so, I consider myself a surgeon of the urologic system, and she's a medical doctor of the urologic system. So we have interesting, dinner table conversations,
I'm
to
sure.
say the least. But so our motto is "You're in good hands." So there's lots of discussions about urine in the house. But,
no pun intended.
Yeah, exactly. So.
That's so funny. Well, that's really cool. Well, thanks for that intro. Some of the things that I would like to talk to you about today, really involve, not just the LGBTQ community, but more specifically trans care. And one thing I get asked a lot about, and I know you've taken care of a lot of my patients for this particular procedure, is orchiectomy. Patients are dying to know what to expect, really. Like, how much does it cost? A roundabout, of course, because obviously you can't guarantee price with payers and whatnot and ever-changing rates, but an average. And how successful are you getting it covered by insurance and that type of thing? And, what pain should be expected post-procedurally and what benefits they may have.
Sure. Yeah. So gender dysphoria is the medical diagnosis that's frequently used for patients that are interested in these procedures. So it should be considered a permanent method of hormonal treatment for gender dysphoria. The procedure itself, we call it a simple bilateral orchiectomy, which basically means we're removing the testicle surgically, but rather than doing what's called a radical orchiectomy, which is made through a groin incision or in the lower abdominal area, such as we would do for a patient with testicular cancer, where we need to remove the entire cord as well as the testicle itself. This can usually be performed as a same-day operation through a simple midline scrotal incision. So, in my practice, it's usually about a 1-inch incision. Obviously, the patient is asleep, so they don't feel or remember anything. We use what we call multimodal pain control, so a combination of general or local anesthesia, but I can perform the operation through that 1-inch incision, whereby we would remove the testicles and use a dissolvable suture to sew the incision back together. So the operation itself, takes about half an hour. And like I said, all patients go home on the same day. Most of the patients do very well in terms of pain control. So, we've started using a lot of local pain control. So the nerves that supply that generally very sensitive area, we use numbing medication during the procedure to blunt that response. And most patients just use over-the-counter Tylenol and ibuprofen to control the pain. So, we'll send them home with a couple of pain pills, only to be used with extreme cases of pain. But the majority of my patients never really even have to fill that prescription or use that medication. So then usually, just because of concerns about bleeding or anything like that after the procedure, I ask them to wear kind of a tight supportive underwear for a few days and refrain from any kind of heavy lifting. Heavy lifting for me is anything more than about 7 to 10 pounds, which is about a gallon of milk if you wanted to compare it to something. But no heavy lifting for about 5 to 7 days after the procedure. And after that, things have pretty much returned to normal. And then I'll usually see those patients about a month after the procedure, just to take a look at the incision and make sure things are healing up well. And then basically return them to your practice to continue with their chronic hormonal management. But one thing, I will kind of touch on, bilateral orchiectomy is a fairly common procedure in urology, whether it's for testicular cancer or whether it's for, hormonal management of prostate cancer. That should be performed for gender dysphoria does have some technical considerations. So, we'd like the incision cosmetically appearing location so that if the patient does major issues, later down.
So the patient that as an option because the vast majority would love to go on to get vaginoplasty if it's available to them. So that's awesome. And I didn't realize it was such a and do you have a lot of difficulties getting it covered by insurance, or is it just dependent on whether or not their plan is inclusive of trans care?
Yeah. So has increasingly been, recognized by a number of insurance companies. I am by no means an expert in insurance companies, but certainly to recognize the diagnosis. That diagnosis, the American Urologic Association recommends that patients be evaluated by 2 independent psychiatric health professionals. So we do require, kind of 2 independent letters just stating that the patient's been evaluated and independent professional for the patient to undergo because it's not a reversible procedure in most cases. So, just kind of being absolutely sure that everyone's in agreement that we should move forward. But, once we meet those requirements to work, I found that the majority of patients have been able to get this covered by insurance. That being said, because it is a 30-minute procedure and can always be completed on an outpatient basis, we do have the opportunity to do this, in an ambulatory surgical center where the patient would go home the same day with minimal anesthesia requirements, which can often reduce the cost of the procedure. But, to answer your question, a lot of these are being covered by insurance companies nowadays.
Okay. But it sounds like should the patient have to pay out of pocket, it's not totally out of reach.
Yeah, again, I'm not an expert in that area, and we can certainly get that information for patients, but I haven't found it to be an astronomical number or anything like that.
Yeah. Well, that's excellent. So the other question I had pertaining to orchiectomy was a lot of patients have concerns about after the surgery, and obviously a lot of that depends, a lot of sexual function depends on, hormone levels. But anatomically, because of the surgery, you expect have an issue maintaining an erection or getting an orgasm?
That's a fantastic question. So, and something that we'll always talk to the patients about before they undergo the procedures. So anatomically, if you think of the function of the testicles, the primary responsibility of the testicles are to produce testosterone and to produce sperm. About 5% of the prostatic secretions and from called the seminal vesicles. So patients should still expect to ejaculate, and that wouldn't look any different for them. The main issue after an orchiectomy is, permanent loss of testosterone. So even in the female sex, we've started to recognize more and more the importance of testosterone, both for males and females in sexual function. But this is primarily for libido. So libido is kind of defined as your interest, your appetite for sex. So occasionally patients will need testosterone replacement to replace their libido. But specifically speaking, testosterone is not a treatment for erectile dysfunction, nor would I someone who had an orchiectomy or permanently lost their ability to produce testosterone to have complete loss of erections. But we may need to replace testosterone, to enhance their libido.
Excellent. Awesome. Well, thank you so much for that information. It's super helpful. Some of the other things, too, that I wanted to touch on that I get a lot of questions about as far as a urological standpoint in the gender diverse community would be genital atrophy for trans women and pain with erections. Typically, and I've only very recently started prescribing topical compounded testosterone. It's like 1% compounded testosterone just to be applied to the genitals and daily Cialis. But is there anything else, like from your standpoint, or am I off the mark on that? Anecdotally, I've seen some good results, but again, it's only been a handful of people. So kind of what are your thoughts on those two issues?
No, I think you hit the nail on the head there. I mean, I think, the benefits of, phosphodiesterase 5 inhibitors such as Cialis, such as Viagra, which we can often use at lower doses in these patient populations. If you look at the way those medicines work, they work to increase an enzyme called nitric oxide, which basically enhances erections or clitoral engorgement. But it's really working by bringing healthy blood supply to the penis. And we know that blood has lots of anti-inflammatory and kind of restorative properties in there. So by putting patients on those medications, either in an on-demand fashion or at a daily low dose, I think it has a lot of restorative properties. And, we're using those medications in that fashion for a number of patients. And I think topical testosterone can be helpful as well. And, we've used topical estrogen, for vaginal atrophy for a number of years. But I think, the benefits of topical testosterone can certainly be beneficial as well.
Yeah. And, we typically, I don't even see a large increase in total testosterone too. They end up just kind of, especially if they've already had an orchiectomy, they tend to just land in like cis female ranges, the topical T, when we apply it that way.
Correct. Yeah. So it tends to support the local tissues, but a number of studies have been done both looking at topical estrogen, as well as topical testosterone, where they've measured blood levels of testosterone, and similar to what you're seeing in your practice, we do not see a lot of systemic absorption or a lot of testosterone that's absorbed into the bloodstream. So
yeah, excellent. And so as far as those topics go, as far as painful erection and pelvic floor pain and things like that, aside from medicines, do you have a lot of success with pelvic floor PT with these patients?
Oh my gosh. If I could get every single one of my patients to go to a pelvic floor physical therapist, I would die a happy man. It just cannot be understated, how detrimental the pelvic floor can be to so many issues in urologic health and sexual health. So, a tight wound up pelvic floor can really kind of make things go haywire. So I am a huge proponent of pelvic floor physical therapy. And, there's it's important that patients kind of understand that this isn't necessarily a physical therapist that takes care of shoulders and ankles and knees, but, someone that's truly dedicated to and has committed their career to the pelvic floor and can rapidly kind of assess the patient, come to a correct diagnosis, and really use a lot of tricks in their tool bag, can really get our patients rehabilitated and feeling better quickly. So, yeah, I agree with you 100%. I mean, for a number of urologic, sexual health conditions, we're always asking our patients to see pelvic floor physical therapists.
Yeah, and it seems obviously kind of surprising, but, for lay people, I don't think a lot of lay people realize that their pelvic floor is all muscles. They don't think about it, and so, of course, just like you said, with a tight back or tight shoulder, you're going to have limited range of motion and dysfunction, but the same holds true for the pelvic floor. And so I think you're 100% right with how helpful the physical therapy could be.
Yeah, and if I can make a plug here, I have no affiliation with this book, but it's just so wonderful that I tend to recommend it to a lot of my patients. But I believe it's called There's a Headache in My Pelvis. It's available on Amazon, and I've had a number of patients, that maybe I had trouble kind of explaining to them the importance of the pelvic floor, that have then, read the book and come back to me, and it just kind of, triggered a light bulb that kind of made this all evident for them. But, we certainly do a lot in the office, in terms of education and pictures and drawings and diagrams and models to just kind of show kind of how intimately involved the pelvic floor is in kind of wrapping the urologic structures. And so, inflammation and pain of the pelvic floor can definitely cause referred pain to these urologic structures for patients.
Yeah, that's awesome. Yeah, I'll make note of that book. And thank you for the recommendation. Hey everyone, I have a quick favor to ask. If you wouldn't mind taking a moment and just clicking the subscribe button on whichever platform you use to listen to my show, that would be wonderful. Not only does it allow you to get notified every time I publish an episode, but it also helps with my ratings and reviews, which what that means in podcast world is that I'm able to climb up in the rating scale and reach other listeners. The whole reason why I started this show is to access people who needed the information. So please just go ahead and click subscribe, then we can all be happy and continue to listen to this good quality free information. Thank you so much. I was going to ask you, and of course we could probably have an entire episode on this particular urological issue, but do you, briefly, can you speak to interstitial cystitis and how that may or may not impact a patient's ability to go ahead and get gender reassignment surgery, or if it has any impact at all?
Yeah, absolutely. So interstitial cystitis is also defined as bladder pain syndrome. So, the hallmark of interstitial cystitis is bladder pain. So interstitial cystitis, is considered a diagnosis of exclusion. And what we mean by that is, these patients, generally will complain of pain when their bladder is full and relief when the bladder is empty. But, as most conditions are in medicine, there can be some gray areas with the diagnosis. So, the first step for a urologist is to rule out, anything that could be masquerading as interstitial cystitis or bladder pain. So, we want to rule out a urinary tract infection. We want to rule out a kidney stone, blood in the urine, a prostate infection that could be mimicking these symptoms. And of course, if we found that, we would treat it appropriately. But, assuming you've ruled all these things out and the patient continues to have pain, one of the first steps is, evaluating the bladder and the urethra with a camera. It's a procedure called a cystoscope. And so when we look in the bladder, there can be some characteristic findings of interstitial cystitis. So, if a patient has ulcers throughout the bladder, that's what we call Hunter's ulcers. We would generally cauterize or burn those ulcers, and that can give patients significant relief. So, the way I explain it to patients is, if you have interstitial cystitis with ulcers, the urine bathing those ulcers is like putting lemon on an open wound.
Yeah, I can't even imagine how painful that would be.
Yeah. So of course we take a biopsy to make sure that it's nothing more serious, but otherwise, there is benefit to cauterizing those ulcers to basically seal it so that very irritative urine isn't continuously kind of bathing that wound. But this true, what we call ulcerative interstitial cystitis, actually only exists in about 10% of patients. The other 90% would have what's called glomerulations, or just bleeding and kind of inflammation of the bladder. And those patients benefit from what's called a hydrodistension, which is where we actually stretch the bladder with water. And, this is obviously generally done while they're asleep, but, that stretching of the bladder can increase their bladder capacity, which cuts down on kind of urgency and frequency episodes. But it's actually been shown to treat the pain as well. And we can often put like a steroid or a numbing medication into the bladder as well. But, going back to your previous point about the pelvic floor physical therapist, these 90% of patients with non-ulcerative interstitial cystitis, the majority of them will have a pelvic floor dysfunction to go along with it. So we'll always do a thorough exam of the pelvic floor. But generally, these patients have a chronically guarded pelvis and very hypertonic pelvic floor muscles, where we'll send almost all of them to a pelvic floor physical therapist to work on relaxing those muscles. And in the worst cases, we have to do what's called trigger point injections, where we can actually put steroid and numbing medication into those muscles to kind of speed that relaxation process. But we always tell patients, there's usually not just one treatment or a magic pill that magically makes interstitial cystitis go away. It's generally thought of as a chronic condition, and it often requires maintenance therapies such as physical therapy, numbing medications, cystoscopy in the bladder. So it can sometimes complicate both the timing, but also the technique of a gender reassignment surgery. It's difficult to sometimes sign these patients up for operations such as urethral reconstruction, a neophallus, if they're having ongoing bladder pain and requiring these recurrent cystoscopies and things like that. So I agree with you. We would almost certainly want to calm down the bladder inflammation before we kind of embarked on a major gender reassignment surgery.
So yeah, it may complicate things, and you would definitely want to get it under control, but it wouldn't necessarily cause someone to not be an eligible candidate.
Correct. Yeah. But I would certainly want to, for them to be symptom free,
right,
for at least 6 months or so before we put them through a big operation, then immediately having to put cameras through a neophallus and a newly constructed urethra to do bladder treatments. We would certainly hope to calm down the interstitial cystitis before we do that.
Right. And not only that, the vaginoplasty itself is an extremely painful procedure. So then you might be chasing this loss of pain after that.
Absolutely.
Yeah.
Absolutely.
And, too, I wonder, I'm familiar with vaginoplasty, of course. I'm less familiar with the preparations because I find that each surgeon does it differently. But I wonder if a general recommendation is to have patients undergo pelvic floor PT in preparation for the surgery, and if that has helped surgical outcomes. Have you seen anything like that, or do you know anything about that?
Yeah, I haven't. Unfortunately, I don't have a paper that I can quote off the top of my head. But having participated in a number of vaginoplasties, it is quite an involved operation, and obviously the vagina is intimately involved with the pelvic floor as well. So I think the pelvic floor physical therapy, would certainly be helpful both before and after the vaginoplasty.
Yeah, for sure. Well, awesome. That's more really good information. Did you have anything you wanted to add to that before we move on?
Nope. I think we covered it pretty well.
Awesome. So the other thing I wanted to touch on was hormone pellets. I get a lot of questions, especially with trans men. They get injection burnout a lot. And, I don't love Androderm, the patch. I feel like a lot of guys get dermatitis from it. And then depending on whether or not they've had hysterectomy or removal of the gonads, I should say, it's almost more challenging, too, to eliminate the menstrual cycle with some of the topical applications. So usually I do lean very heavily on injectables for that. But, I get a lot of questions about once they're well maintained on their transition and their hormones are steady, or if they've had removal of the gonads, if pellets are an option. And I don't really have a lot of providers here in Atlanta to refer them to. And so I get a lot of questions about that. And I know that you do the pellets. So also, I know you do them too for trans women. So I'd love for you to talk a little bit more about that because, it's kind of a new thing here. I know it's very much used out on the West Coast. That's more progressive, in the more progressive areas. But here in Georgia, it's not considered a very common option for these patients.
Yeah, absolutely. So, hormone replacement is, obviously something near and dear to my heart as an andrologist. But, I kind of go through all patients, in all scenarios that are looking for hormone replacement that, really we do have a lot of options. And, the way I try to educate them is, what are these different options? What are the mode of delivery? But also, kind of what are some of the what we call pharmacokinetics, or how is the patient going to interact with that medication? So, generally hormone replacement exists in a few different preparations. So probably the oldest and most common is the injectables that you talk about. So, testosterone cypionate is probably the most common version of that. Most patients will inject themselves, every 2 weeks, sometimes every week. And there can be some injection fatigue from that. There can be some pain from that. Obviously, lots of supplies and needles, frequent trips to the pharmacy. But from a pharmacokinetic standpoint, what patients often complain about is they feel great on the first few days of the injection, but by the time it's 2 weeks have passed and it's time for the next injection, they're really feeling burnt out. They're really feeling like they need their hormones, and that kind of mirrors the pharmacokinetics. If you look at the curve, testosterone levels really spike in the first few days after the injection, but they tend to taper off as time goes. So, my patients that are in injections, I'll often half the dose and have them inject every week instead of every 2 weeks to kind of overlap those lines and try to give them a more consistent level of testosterone. All of the dermatologic preparations, whether it's a patch, whether it's a gel, it's really difficult for us to know kind of how each individual patient is going to take up that hormone. And so that kind of forces us to have to titrate the medications, do lots of blood work and frequently check in on how patients are doing. I always talk to patients about the theoretic risk of transference to like a partner or a child or another loved one in the house. So, when you're putting these agents on the skin, you certainly need to be careful about that as well. But the pellets have really helped my practice. The pellets, simply put, are subcutaneous pellets that we'll usually place in the upper outer buttocks area. So these pellets, it's basically a 30-second procedure in my office. The patient is awake, kind of laying on their stomach. We sterilize the skin in that area, and I put some numbing medication in. And then we have an applicator device where I can put pellets underneath the skin. So we have testosterone pellets, we have estrogen pellets. We're not using progesterone very often in a transdermal fashion, but certainly we can do testosterone and estrogen or even combination pellets. But these pellets will usually give the patient a slow, steady uptake of either testosterone or estrogen for a 3-month period. And so the first time we do it, we'll usually check blood work about 6 weeks after the pellet procedure to see kind of what is their mid-cycle testosterone or estrogen level. And we'll use that to kind of reach a decision on how many pellets we're going to put in, the next time we do the pellet procedure. But once the patient has kind of, reached their steady dose of pellets, then this is just a procedure that they need to come into the office maybe 3 or 4 times a year and just have the pellets placed. So, patients that, frequently say, hey, I love this. I just come to the office. It takes 30 seconds, 3 or 4 times a year. I'm not having to inject myself every couple weeks. I'm not having to go to the pharmacy. If there's compliance issues, they're not having to remember to take their medication or say, hey, did I do this last week? Did I not do this last week? I can't remember because I didn't put it in my phone. It kind of takes a lot of those, things out of play. So patients have liked it. From the pharmacokinetic standpoint, they really like the fact that they get an even distribution of hormones over that entire 3-month cycle. So that's obviously been very nice for patients as well.
Yeah, that's awesome. So what kind of levels are you looking for when you say mid-cycle?
Yeah, so I think once you've made the diagnosis that hormone replacement therapy is necessary, I'm almost always treating the patient rather than the numbers itself.
Right.
So we like to keep patients, in a safe range, and that can vary, kind of depending on, what condition you're treating, whether it's, low testosterone or if this is just, post-orchiectomy testosterone replacement. It really varies on, what the condition is that you're treating, but certainly, the patient's symptoms matter more to me than kind of what the absolute numbers are.
Yeah, for sure. So when you're doing it for transgender medicine, do you find that the testosterone does aromatize into estradiol very frequently, or you're not seeing those increased levels?
Yeah, we frequently do. And if that's the case and it's bothersome, then we can add a medicine like Arimidex to prevent, that peripheral conversion to aromatase. And that's something that we'll frequently do for these patients.
The other question I had pertaining to that is, there's a lot of talk in the community about, endometrial lining with, estrogen present. While we know that testosterone is extremely atrophying to the internal biological female organs and that it's unlikely even in the presence of estrogen for them to develop an endometrial lining, do you have specific recommendations as it pertains to the pellets on monitoring for that, or is it not something that you've had to encounter before?
Yeah, honestly, I haven't encountered that a whole lot. I mean, I'm sure that's probably something you can teach me on, but I honestly haven't encountered that a whole lot. What are your thoughts?
Well, typically, I just tend to monitor the estrogen levels, and I try to treat elevated estradiol as I would for a cis male. So anything over 70, especially if they're having cramping or bleeding, I treat obviously with Arimidex also, just to get it down into a normal range. But as far as monitoring for the endometrial lining, I kind of defer to gynecology for that as well, as far as their routine follow-ups. But everybody who has had a transvaginal ultrasound has not, to my knowledge, any of my patients had any kind of endometrial build up as long as the estrogen levels were not elevated. So I was just kind of curious to see, because I find with the topical gels that the estrogen levels stay really high in that population. And so then I do get concerned if they are still with a uterus that it might, even though the testosterone atrophies those organs, I still get concerned that with that estrogen, unchallenged estrogen, it could develop. So that's why I was curious what kind of levels you see or how common it is for you to see high estrogen levels with the pellet application.
And that's fascinating. I think everything you're getting at just, I think, highlights the importance of a really strong kind of multidisciplinary team. It's I think well documented in the literature and understood that you have to kind of approach these cases from a number of different angles. And so kind of having a cohesive team that has, strong communication is I think key for kind of good outcomes with patients.
Yeah, absolutely. So with the timing of the estrogen, have you seen, what kind of levels do you get with the estrogen? Because typically I find that the estrogen levels have to really surge and be above 400 for feminizing effects to occur. Is that the kind of levels that you get with the estrogen pellets?
Yeah, so I honestly I haven't seen levels that high, so I personally haven't experienced that, but I don't want to obviously speculate on the podcast or anything like that,
For sure.
So... But yeah, I haven't seen levels that high, so that's interesting. It's something I'll have to watch out for, obviously, so.
Yeah. Well, I was just curious, have you placed a lot of pellets for trans women?
So I wouldn't say a lot. We definitely do a lot of estrogen replacement, for non-trans women, and tons of testosterone replacement for trans patients. That's something that we're doing, very commonly. Estrogen, I think, is something we can offer, but not something that we're doing a whole lot of routinely.
Yeah. So, well, cool. We can always navigate that together on a case-by-case basis. Yeah.
Yeah, absolutely.
Yeah, because that would be really beneficial because, right now I only have a couple of patients interested in the estrogen pellets, but, some of them have fully completed their transition. And so we're really just looking for maintenance, like if we would like a postmenopausal female, rather than actually initiating a new puberty. So, yeah. Yeah,
that would be great because we can work on a protocol and, I'd love to learn about that with you and just kind of, I can look up some papers and even talk to folks around and we can get a solid kind of pellet program together for them.
That would be really helpful. Cool. Well, just to summarize our discussion about pellets, it sounds like both are very viable options as far as testosterone and estrogen. A little less is known about estrogen pellets, but definitely willing to offer it to the patients. And it's something that we can navigate and discuss with our patients on a case-by-case basis.
Absolutely. Awesome. Yeah. And we of course are, more than happy to see any of your patients and, and answer any questions they have. Telemedicine is something that's kind of evolving and new for us that I think is one of kind of the pleasant surprises that we've had, amidst this, very unfortunate corona pandemic. But, that's certainly given me the opportunity to, connect with more patients from the comfort of their own home or, if geographically they're kind of far away from my office. So these are all things that we love to discuss with patients, either in person or online.
Yeah. So that's good to note too. So you are accepting new patients. If people can't travel in, you're able to at least do the initial intake over virtual medicine?
Absolutely. Yeah. So our practice, has 7 locations in the metro Atlanta area. They're all full service locations with the surgery center, but also lab and ultrasound services. So, very commonly I'll meet with folks for their initial telemedicine visit. And if labs or some precursor workup is required, they can get that done close to home. And then we can have a follow-up visit, in person and kind of keep the ball rolling without, too much disruption because of travel and things like that.
Awesome. So if patients wanted to connect with you specifically, what's the best way they could reach you?
Absolutely. So our website is www.advancedurology.com. And I can also be reached on all the social media platforms, Twitter, Instagram, and Facebook at Chirag, CHIRAG, DAVE_MD. And so again, love to hear from patients, love to interact with patients on social media, but we have same day and next day appointments available all the time. And you can book those from our website, advancedurology.com.
Awesome. And we'll list all of those too in the podcast summary for patients to be able to refer to and get in touch with you. It was so good to speak with you today, and I thank you so much for your time. I know you're really busy and had a long day doing surgeries and seeing patients. I totally appreciate your time, and I think it's going to be extremely valuable for all my listeners.
Thank you so much for having me on today, Erin, and it was a pleasure to meet your audience and the community, and look forward to seeing some of you in the clinic soon.
Awesome. Thank you. Remember, everybody, stay fierce and live your truth.